right, let's go ahead and start main round. Metoyer is fourth year Med Team president who will be graduating in June. And she picked a really important topic for us, which is toxic stress, the role of the pediatrician. So I think this is good for all of us to be aware of and how important it is for us to recognize. So we'll let you get started.
All right. Can everybody hear me? I realize that I do not talk as loud as I hear myself in my head. So I chose toxic stress and the role of the pediatrician, mainly because once I started doing the research, I found that what happens in childhood really affects what I see in my clinic as I see adults as well. And as you know, I don't know if y'all have seen the patients that we have, but they've had probably some toxic stress going on in their lives, so it seemed pretty relevant. I have no disclosures. I really wanted to do this because I'd like all of our children to be able to kind of grow up and do what they want to do and have some good role models. So our objectives for today, one is to adopt the eco-biodevelopmental, and I'll be referring to that as EBD the rest of the time, as a means of understanding the social, behavioral, and economic determinants of lifelong disparities in physical and mental health. Two, to identify your patients at risk for toxic stress so that you can refer them for early intervention strategies and then prevent known associated adult diseases. And finally, to advocate for the development and implementation of new evidence-based interventions that reduce toxic stress for your patients. Battery? Yeah. Or it sounds like it.
Yeah, let's see, that should be our place.
Jump jobs.
You don't have to do it.
Just short now.
Oh, yeah.
Yeah, that's what we just got.
I think it's just going in and out, so I figured it would.
Yeah, you may need to.
See if those are fresh. Somebody just put the old ones on there. I'll just smash them.
Okay. Yeah, that's one to get. There we go.
Maybe that's how I was supposed to get it out. I think it's staying on.
It's just going in and
It was
out.
going in and out, so we couldn't matter.
It was downstairs, we could hear you.
Oh, okay.
Okay,
They could-
so we just changed the battery.
Okay.
Okay,
I think we're good.
all right.
I think we're good. All right.
I think that works. Okay, great.
Okay. Sorry. So what's happening today? Right now there's a childhood obesity epidemic. You're seeing kids that have type 2 diabetes and they're 8, hypertension, and there's no other secondary cause. So what's going on from Generation X to our triple R's generation that we're seeing right now? So in 2008, based on this epidemic, the AAP started addressing these issues. They said that there's a new urgency given this epidemic of obesity. There's an increasing risk, kind of like what I was talking about. And so they wanted us to start taking a more proactive approach to childhood to prevent these cardiovascular diseases that we're seeing both in childhood and in the adult. They recommended certain dietary guidelines, increased physical activity, treating dyslipidemia early so that you can prevent that atherosclerotic disease. So how do we do this right now, and how does our current healthcare system look? So as a pediatrician, we focus on the provision of immunizations, we do anticipatory guidance, we look at early identification and management of problems within our primary care. As an adult physician or as med-peds, we start looking at these behaviors in adults, their nutrition, increasing their exercise, all the things that I don't do. So we'll see what I look like down the line. So it's a challenge, and so by the third step, we're trying to reduce these threatening behaviors in adults and also some of the maladaptive behaviors that they have, like smoking, alcohol, drug use, high risk taking behaviors. But what I found in the research and kind of what we're going to be learning about today is kind of a different framework for how to kind of implement these same ideas, but just in a different context. So the reason why we do the things we do now is because these adult conditions were initially thought to be the sole result of just adult behavior and lifestyle, which in my case it is, but there's some more knowledge. What we know now is that in these behaviors and their health risks have actually been influenced decades earlier. So things that happened in the past have actually influenced what we see in the adult population. So in your mind, just have it in the back of your mind that of a good beginning cometh a good end. There was a study back in 1998 called the Adverse Childhood Experiences Study. It was the largest study ever to be done at that time, looking at just this same concept. How do these childhood experiences affect who we are and what happens as an adult? They looked at 7 different childhood experiences, such as childhood abuse, neglect, domestic violence, parental discord in the home, exposure to violent crime, and also substance abuse, and looked at how those affect risk-taking behaviors in adults, like the ones I was just discussing, like smoking, alcohol. They're also like coping mechanisms that they have. They also compared it to certain diseases, like that actually lead to mortality, like known cardiovascular disease, any type of cancer, stroke, COPD, just all the things that we know are like our top 5 or 7 reasons for mortality. What they found was that there's a prevalence and risk increased for some of the factors, including smoking, obesity, physical inactivity, having a depressed mood, and suicide attempts as those numbers of adverse exposures increase. So the more adverse exposures that you had as a child, the greater those risk factors were. And also there was also a graded response with the types of diseases that you had. So people that had cardiovascular disease already or diabetes, they were found to also have been exposed to other adverse childhood experiences. Of course, this study was, it was based on questionnaires and kind of their own recall. So some of them are trying to recall these past experiences that they had, and also it's a little bit limited because there is no causality. So this is something we're looking at adults in their 50s, 60s, trying to recall what happened in childhood, and obviously there's been a lot of exposure and things that happened, including their poor behavior during this time of life that probably influenced that, but it did suggest that there's some causality. So what we're going to be discussing today is how these adverse childhood experiences kind of lead to social and emotional cognitive impairment in the child, which then kind of lead to an adoption of health risk behaviors, disease, and eventually early death. Based on the ACE study, there's been several studies since then which kind of demonstrate some of the same things, and I was just kind of showing you different ways. So they also looked at ACE and depression, the same thing. They showed that the graded relationship between the significant number of adverse childhood events and depression, and it affected both men and women. So they kind of wanted to control for gender, and then they controlled for the type of abuse. So women and men kind of paralleled the same, except for in the case of physical abuse, it seemed like men were more prone to have been physically abused as a child, and then that led to their more adverse events later. So this is just a picture of what we're talking about. So these are the number of adverse events that they've been exposed to, and they're given like this adverse event score. And then this is, for instance, the odds of having heart disease. So people that were exposed to 7 to 8 adverse childhood events are 3 times more likely to have some type of heart disease later in life. So based on this, what I wanted to show was kind of how this science came to be and kind of where we are now. What we didn't know back then was how one's adverse childhood experiences even affect the child, and how that how in the world would that lead to adoption of a health risk behaviors later as an adult. So let's start with children. The brain is developing all the time, even here like before birth. So these are where these synapses are even just beginning to form, and they're being influenced by the environment prenatally. And then as you continue to grow, these things kind of differentiate, they become more complex, and that's based on how they're interacting with their environment. So it's not just what's happening prenatally, and it's not just their genetics. The environment comes into play. So we used to question like nature versus nurture. Does that, does one or the other lead to alcoholism? And what we found is that it's kind of both. And there's an interplay all along from birth into adulthood even, is what we're discovering now. So there's a serve and return relationship when we're building these synapses. And you'll see here, this is what they look like at birth compared to 6 years to compared to 14 years of age. So 700 new neural connections are formed every second. These connections are formed through the interaction of genes. So these were already here based on our genetics. But then as the baby's environment and their experiences influence them with their interaction, they build more and more connections. And these are what build their brain architecture, and that's what we see later with their learning, behavior, how they interact with the environment. And we'll talk kind of a little bit about this. What we know is that they need stable and responsive relationships in their environment in order to form a big brain like what you want to see in a child. They're very unique, and I learned this new word called attriciality. And this is the fact that they're born in an underdeveloped state, and this is every species, but they're requiring care and feeding by their parents. And if you think about our kids that we take care of, or the kids that you have at home, they are solely dependent on you when they first come out. And it's very unique for humans because we're the only ones that are that dependent. It seems like as an animal, they feed you for a little while, and then, you're kind of on your own. But for us, we need our parents. They do, we have to change their diaper, get their bottle. They're completely helpless if we're not there. And these positive bonds that happen as a child are what influence what they look like later on as children, as preschoolers, adolescents, and even as adults. So it affects all these aspects of their system. So their emotional health, how they respond with stress, their immune competence, and also their health-related behaviors. So neurons that fire together, wire together. Here we see that early experiences will stimulate a wide variety of nerve transmissions. So it's not just the effect of just what they see, it's affecting their behavior, it's affecting all different parts of the brain at the same time, even when you just give them a bottle. So you're you're serving a need. So they sent out a cry, you gave them a bottle, the return that they got, it stimulates all different areas and it connects all together. So what they need is that these positive experiences need to be repeated in regular, predictable patterns. And that's how you get these neurons to actually form and build a good architecture. So as these connections happen, they become more and more efficient. Infants are soothed, like if they're crying and you soothe them immediately, they learn that serve and return. So they know that when I cry, my mom comes, and that's less distressful for them. What if as opposed to if they're eating at 5 o'clock one day, then you put them to sleep at 5 o'clock the next day. In the morning, you'll feed sometimes. In the afternoon, you feed sometimes. Like, they don't learn that serve and return properly. So it's kind of random to them, and they don't know what happens. So I cry, and I don't know what's going to happen. I might eat, and I might just have to stay here and cry. And that causes some stress to them. And so their biological systems don't learn these healthy routines, they don't learn self-regulation, and then it leads to later disruptive behaviors that we see, poor cognitive performance, and risk of unintentional injuries. And what I'm going to show is why that's happening. So this is what I'm talking about. This is known as neuroplasticity. So what happens is our routines empower our brain. So there's some mental activity that happens, your brain gets stimulated, it creates new neural structures, and then there's repetition of that activity so that they're connecting one and back to the other so that synapse is kind of strengthened. And that's kind of how we build our brains. And there is a level of neuroplasticity lifelong, and so that's what we're going to kind of be demonstrating. So basically what I was just saying is that this is an iterative process, so it reinforces itself by the repetitive actions. What we know, though, is that there's some critical windows of opportunity where the effect that you have as a child is going to affect what happens later as an adult, and it has large impacts on development. The problem is that the brain adapts to both the positive and the negative environmental stimuli. So the ones that have a good mom and very supportive turn out a little different, and the ones that have a negative experience also have some effects on their brain as well. So you all remember epigenetics. I'm not going to go too deep into it. We're just talking generally just to look at it. What we know is that responsive caregiving plays a role in both brain architecture as well as the neuroendocrine system. That would be like your HPA axis. Any type of variation in quality and quantity of maternal care, like I was talking about, can actually affect even the mom, and then it affects what genes she passes on even to her own offspring. So if she had a very responsive mom, then the genes that get turned on in response to that will be passed on. And then the ones that weren't turned on and the ones that weren't stimulated in the brain, those are going to be missed. And the reason that happens is through epigenetics. So things that are methylated, and I don't remember all the details. So there's some genes that are involved, and we'll talk a little bit about that with rodents. So a lot of our studies and what we've learned from animal behavior, because they also do this attritionality. So in rodents, there's some variations in maternal care. That's demonstrated through licking, grooming the little small rodent. I don't like rodents, but that came across. But as they're doing this, it creates a different response in the baby rodent. So if they're born to high nurturing mothers, then we see that they actually have a regulated, modest response. So their stress response that they exhibit is actually lower. If they're actually born to low nurturing mothers, then they have an exaggerated response to stress. So they're like a little high energy rat that I'm probably freaking out about. And they exhibit a lot of fear and anxiety as well. But what we did see is that if they're born to low nurturing mothers, so that would be their genetic possibility, their environment actually shaped them. So then if they were given to a high nurturing mother, despite the fact that they were born from a low nurturing mother, they developed a regulated HPA response. So it's an interplay between your genetics and your nurture at the same time. So what this is just to say is that the body makes these epigenetic decisions as an adaptive process. Genetics provides the blueprint for who you are and how your behavior is going to be, but your environment determines which genes are used, how they're used, when they come into play. And the same thing happens with the fetus. So a fetus born to a mom, let's say, who has poor nutrition, poor environment, they're actually experiencing prenatally inadequate calories, nutrition. The body undergoes certain, as it's building and forming the fetus inside, the brain is responding to this. So it's saying, oh, I'm not going to have enough food when I get out. So it turns on certain genes that are going to say when it gets out, I need to save all the energy I can get. But what happens when they're born into our society where you can get 2 things at McDonald's for $1 as opposed to just 1 thing? And so you have lots of donuts available as opposed to no donuts available. Then what we have is a body that's ready to conserve all the energy it has, and what it has is an abundance of food. And so it's backwards. And so that's how we get the risk of later obesity, these metabolic disorders, because actually our genetics are prepared for one thing epigenetically, but our environment was shaped differently. This is known as biological embedding. But what we're going to talk about now is just how the brain adapts to negative environmental stress and whether or not all stress is damaging. So what I wanted you to see was just how the environment forms, how that affects the brain, and then the main topic today is going to be toxic stress and just how that, the same thing, so some negative stimuli and how that affects the brain in a negative way, in a negative architecture. One example is neglect. It's been highly studied and looked at. There's 4 types that we'll discuss. There's one called occasional inattentiveness. This is what happens with all of us. Sometimes our babies are crying and we're actually trying to fix the bottle, or I just need 1 second to go to the bathroom, take a shower, and it's crying and I just need a minute, you know. So this is occasional. We are going to go back and respond to that child. We're going to attend to its needs, figure out what it needs. But what happens is with its brain, this still is getting a serve and response. There is some absence, but it builds resilience. So while you're not there, the kid is exploring its environment. It's going to learn to self-soothe sometimes, and you'll be able to go to the bathroom by the next month. In the other case, there's such thing as chronic understimulation. So some of our kids don't have such responsive moms. Sometimes those moms are working and they have to be left at daycare, and maybe you have a high ratio of kids to adults, so that adult can't tend to 20 other crying babies at the same time. So sometimes they're chronically understimulated, so there's no one that's responding sometimes, so their brain is missing that connection. What we found is that this leads to some underdevelopment of the brain, but it could be repaired. So if that same child was born in a poor environment at home, but then they did have some good responses at their Head Start or at their daycare, they had some nurturing relationships, the brain can repair itself. So that's that neuroplasticity that we were discussing. But there are some bad forms of neglect. For instance, there may be severe neglect in the family context. This would be the chronic understimulation plus the fact that they have unmet needs. So they're not getting enough to eat, they're not clothed, maybe they're not bathed every day. These things have negative effects that really aren't as easily recoverable. So these have some permanent damage on the brain, and this is known as toxic stress. And that's what kind of leads to some of these adverse behaviors that we'll be talking about. And at the same time, sometimes we forget about severe neglect in an institutional setting. So these will be our kids that end up in orphanages, or even when CPS takes the kid and they end up in some transitional housing or assessment. This affects the kid, and sometimes we don't think about that, or that's not in the context of our brain. We're trying to protect it from its poor chronic understimulation and family context, but then they go to an environment that's the same. So imagine a kid in a crib that sees a different person every shift. So every 8 hours they're seeing some different adult, somebody else is coming to tend to their needs, but they're not getting that family bond or that established bond between a mom and a kid, and that serve and return. So they're missing those stimulations to the brain. This is kind of just the taxonomy of stress and just how we're going to be thinking about it while we're talking. So there is such thing as positive stress, kind of the same thing as that inattentiveness that I was talking about. What this causes is some brief increases in heart rate, mild elevations of the stress hormone level, so cortisol. So if you fall and skin your knee, or you break a bone, maybe there's a storm in the middle of the night, or a small rodent ran across your feet, this causes some positive stress. You have a heightened response to that. But based on your secure environment and the fact that you know that mom's coming to pick you up after you fell, or all of you aren't going to let the rodent eat me, like, I'm able to calm back down and handle my stress. What tolerable stress is things like divorce, or those natural disasters that happen. These are some inadvertent things that they're not going to be able to help. These are adverse events that are going to happen to the kid. But if they have a stable relationship, then it's buffered. So if they know that they have some security at home, or they've already established that as a child, then they're able to kind of tolerate these increases in the heightened response of the stress. So they don't turn into the rodent that was under-nurtured, where it's just got so much fear and anxiety that it can't handle itself in a normal environment. So the supportive relationships are going to be really important. Toxic stress, however, is where you have prolonged activation of the stress response, and then you don't have these buffering relationships. So toxic stress is going to be these chronic environments, like a lot of our kids that live in poverty, also food scarcity, so if they don't have a lot of good food, or if they went through some of those same experiences that I talked about in the ACE study. So they've been exposed to violent crime in their own home. They're seeing drug addicts every single day. They're seeing domestic violence, even abuse of their own. So these things are what we call toxic stress. There is no buffering. So they see this every day, and it's a constant stress response constantly. So they never get to come down. So the same things like the brief increase in heart rate, those mild elevations in that cortisol are constantly activating. So what we know is that healthy development, or those genetic things that we already know, can be derailed by excessive or prolonged activation of stress, and this is toxic stress. This is just a little demonstration of kind of the way the rest of the talk will go and kind of what's happening. So here's childhood adversity and our genetic predisposition. So not everybody that experiences toxic stress doesn't make it. You know, there's kids that do just fine despite what they've been through. They'll tell you their stories and you think, wow, how in the world did you get here? So that happens. This is how we influence with those sources of resilience, or those buffers that I was talking about. And these are some precipitants of stress, so sources of vulnerability. What that causes is either positive stress, tolerable stress, or toxic stress, depending on the nature of the stressor and also how their environment is. And what that does is it causes some changes in the developing brain. So they're not establishing those full synapse connections, those complex connections that we need. What this can potentially cause is altered learning, altered behavior, and altered physiology. And that eventually leads to those risk factors that we were talking about before. So fractured social networks, they don't know how to interact with other people, school failure, dropouts. These are some of those unhealthy lifestyle factors, and this is going to be the changes to the immune system and inflammation. We know that that's how we get to these diseases, and then we end up with poor health disparities. So what's the science behind the toxic stress? Basically, there's an accumulation of damage over time, and then that becomes biologically embedded into our brains. So there's two ways that they kind of think about these exposures. One way is that there's kind of like two theories, and I kind of think it's all a mesh of them both together. But one idea is there's a cumulative exposure to stressful experiences, and that's what causes the damage. In this way, there's repeated encounters of this physiologic experience. So there might be increased numbers of traumatic events that lead to a greater prevalence of these impairments. This is allostatic load. So as your brain is developing and you have these poor responses that kind of increase that cortisol level. So the cortisol is going to be causing this heightened response in your body, those same reactions that we were talking about. But eventually it's kind of overloaded. So the feedback mechanisms that would normally shut all that down and let you come back down to normal and calm down are constantly on overload. And so when they're not able to turn off, it's like they have this physiologic dysregulation. So you may just say, I don't really like your shoes today, and they respond in a way that's very heightened to, almost threatening to them. And it's because they're already been set off. So it's kind of a cumulative experience. Another thing they've shown is that it actually leads to high sensitivity CRP levels. That's one of the immunomarkers that we know leads to cardiovascular disease, or at least puts you at risk for cardiovascular disease. The second theory is that the adverse events, what we see is that they're latent effects of these stress at sensitive periods. So the critical moments that I was talking about, something happened in the critical moment of the brain that led to this dysfunction. For instance, like inadequate nutrition, recurrent infections, poor living conditions early in life are associated with these diseases later. So during that critical period when they're building their immune system, learning how to respond, they had these insults that happened that led to these later diseases. For instance, we know that low birth weight is a risk factor for heart disease, hypertension, all of these responses. And early maltreatment and poverty are also associated with an increased immune response. So why is all this happening? What's cortisol doing in your brain? We know that cortisol goes and it attaches to your glucocorticoid receptor. That receptor is actually found in these three areas of the brain in particular. One is the amygdala, so we know that that's activated during increased stress. It's responsible for our impulsive behaviors, our aggressive behaviors. What they saw in several studies was that there's an increased volume of the amygdala in, for example, PTSD. So PTSD is an example of that hyperarousal. We know that something happened in their past, and now they kind of relive it, and they exhibit this exaggerated response. So they're sweating, their heart rate's up, it's almost like they're there again. And so this is an example of kind of how that toxic stress is occurring. And what we know is that's constantly being stimulated with those receptors, so the volume of the amygdala is actually getting larger. The hippocampus is involved with new memory formation. If there's chronic stress, what they showed in studies was that there's a decreased volume of the hippocampus. So in some ways that's adaptive, because maybe if you can't form new memories, maybe you won't remember what happened to you as a kid. Maybe you're not forming those. It's just almost like a protective mechanism is one theory. I kind of think that would be nice, but it's kind of hard to say. But the prefrontal cortex is important. It's the one that regulates the behavior of those impulses and emotions by the amygdala and the limbic system. So if chronic stress is altering those formation of those synapses in the prefrontal cortex, then you have a poor, it's like a a poor stop or a poor inhibitor. So you're already getting stimulation to the limbic system from the cortisol, and then you're also limited in your ability to react to it. So you get this heightened response all the time, and then there's no prefrontal cortex or nothing above you that says shut that down. So it's a constant drive in there, and that's how I think you get that allostatic load that I was discussing. And then you get poor adaptive function. So you don't know how to adapt from one environment to the other because you're not thinking about it anymore. It's just a drive response. That fight or flight is always on. So this is kind of just what's happening. So this will be a normal brain architecture. These are the way your neurons will be connected. As a result of toxic stress, you see there's way less of these synaptic connections in both the prefrontal cortex and the hippocampus. This is just a pictorial, kind of like just a picture of just what's going on. So there's some stressor stimulating your hypothalamus, which then stimulates the pituitary and hits the adrenal glands to produce this cortisol. Where is that cortisol acting? On your cardiovascular system, all the systems of the body, and also on the immune system as well. And so what you're getting is just this heightened cyclical response of just this high stimulation of this HPA axis. So there's been some studies through the years just about how different biomarkers of stress, like one would be cortisol, two would be looking at the size of the amygdala, hippocampus. They've learned to do MRIs and things. The studies I was telling you about was measuring hippocampus volume to PTSD. So we've kind of talked about that, how PTSD will overactivate the stress response system leading to that load. Other studies kind of looked at how this looks in youth. So when they look at the brain of adults, they know that the amygdala or the hippocampus is smaller. But in kids, they didn't replicate that. There wasn't always a true different size. Some studies showed it, and then some didn't. So that kind of suggested that it really is the chronic nature of the disease. So that kind of went back to that cumulative nature. So if they had an adverse event, you looked at them as a preschooler, maybe their hippocampus wasn't that shrunken yet, and that suggested the idea that maybe this is, chronically and what's occurring over the entire length of time, as opposed to that initial insult and then your brain shrinks. Like, it just doesn't happen that fast. So in terms of childhood development, this was just to kind of demonstrate that same thing. So just the number of risk factors, you'll just recall, kind of caused what happened in their life actually led to these developmental delays. So it's just another picture of what's going on. So what I wanted to show was just kind of a picture of really what's going on, just to kind of summarize everything. What we learned earlier was that if they have responsive caregiving, then they get a certain structure of the brain. They're building those complex synapses. This is the supportive social environment and that type of support, family functioning and trauma. So all these things are going to happen in their early social environment, and we're not going to prevent those things from happening. I can't control who you were born to. Certain traumatic events are just going to happen. We don't control those natural disasters, the random wrecks that happen. They're going to be exposed to that. But what you want to have is this buffering from some sort of supportive adult, whether that be the parent, the teacher, their mental health provider. These things matter, and the reason they matter is that they buffer this cycle that happens. So their brain development, which we know already happens with that neuroplasticity, affects what happens in their immune system, and that affects the stress response that they have. And that's what leads to these developmental outcomes that we talked about. If we can buffer them, the hope is that we're able to decrease their infectious disease risk, decrease their chronic disease risk, their cognitive learning. And all these things have long-lasting effects. You as a pediatrician, 1/3 of your practice is going to be helping patients with mental health disorders like ADHD, mood disorders. All those things are associated, what we found, with toxic stress. So those things matter. So if we can learn why that's happening, then maybe we don't have to give them so much medication, as opposed to just learning what's happening and kind of give them some supportive environments early on. The same thing as a medicine physician. Yes, I can teach them how to take their insulin. Maybe I can teach them how to eat right, diet, and exercise to prevent the later effects of that disease. But if we could figure out why all this is happening, maybe we can start to put in some preventative measures before we get to that level. So it's easier to build strong children than to repair broken men. What we found here is that this is cumulative vocabulary. So everybody kind of starts out a little bit the same. But let's say they compared college-educated parents to working-class parents to welfare parents. And what happens is that as they progress, this disparity becomes even larger. So this just shows you your environment really does matter, even for your language. And so that's going to create people. You want to, I guess it's important because you also want a good workforce that's out there. You want to have economic productivity so that we don't have everybody on welfare or everybody either in jail or no productive citizens of society. Your kids are going to be growing up with these people. So you want to have good fostering relationships, good fostering environments. So what makes the difference between kids that have maladaptive behaviors to those that are going to kind of continue on that trajectory that they all started on initially all together? Basically, it's all kind of boils down to that toxic stress. So what I wanted to really just show you all was what's going to be your role. The new policy statement by AAP is that we do learn about toxic stress, learn how it affects children later down the line, and how can we learn to put in some preventative measures. It's all kind of theoretical right now. There's not really an evidence-based study that says this is the exact way to prevent toxic stress or this is how we mitigate that stress, but it has to be in your mind and it has to kind of shape our future policies that are coming down the line. So what we just talked about was what's known as the EBD Framework. This is kind of just a summary of everything we just talked about. So the immature organism reads its environment and then it prepares to adapt to the world. So this is what's happening as prenatally as well as their infant. When they're exposed to toxic stress, their bodies retain that initial programming, but then it's on a heightened short fuse response. So every little thing sets them off. And what we know is that that has long-term health consequences, like I was just discussing. So this is a big area, and this is kind of where we are right now. So we know what it causes, and our role now is to figure out how do we stop it and how do we prevent it. So as a pediatrician, our lives are filled with prevention. We tell them how to wear their seatbelts. We tell them to lay the child on the back to prevent SIDS. We do a lot of anticipatory guidance, and so that's why the pediatrician is going to be critical to preventing all of this. I, as a medicine physician, I could tell my adult patients all day that things that happen to them as a child are affecting them right now. That means nothing. So it's going to be up to you all to kind of influence what's happening right now. Some of this is a little bit theoretical. There are some 7 C's of resilience was one thing, like one policy that kind of was really good. Reach out and read, which is actually long standing, but what we're finding now is the reason why it's actually working. So handing them a book is actually encouraging them to create that parental bond, for instance. So obviously when they come for the 2-month-old visit, the child has no idea what a book is, nor does it care what the words are. But when the mother is interacting with that child, then they're establishing that parental bond. I'm talking to the kid. I'm establishing some relationship. The TV isn't raising my child. There's a serve and return to the kid. Another suggestion was home visiting. So a lot of times these parents, as much as we think there's enough to do in the office and that they completely understood what we said, they don't. They go home and grandma says that you don't need to read the book because what is it doing? They just threw it on the floor again. So who needs that book? Throw it away. They see that what you could see is at-risk use. So you could identify those with a potential for problems. So maybe in the office everything does look great, but maybe they don't have enough food in the home, or there's a lot of violence going on in the home. Then you could kind of identify them early on, refer them for some intervention or some strategies, and kind of prevent some of these things. And fourthly, one of the things was creating some high-quality early childhood programs. So it's really important, like what daycare they're in, how much stimulation they're getting during the day. Head Start is a very good program, and it's for the preschool age. So there's a reason why they target that group of children. And the idea is that we need to train them to also have this toxic stress in the back of their mind so that the policies they implement or the programs that they do with them kind of buffer that system, and just kind of having that in your mind for your at-risk kids. And that would lead to positive educational achievement. So along with that would be primary prevention, so preventing it from the top level. Secondary prevention is after all this trauma has already occurred, what do we do with these kids now? They have to learn some coping devices. One thing was be able to do some psychosocial assessments when they're in the office, with some anticipatory guidance. So you find out what happened to them. What do you say to them now? How do you influence their mental health at this point? How do you intervene with those kids? One study was mindfulness training, so it's kind of like a cognitive behavioral therapy that they undergo. They kind of did this study where they did a randomized control trial in two, I think it was 2 schools. They were lower income schools, so people that would likely be at high risk to have had these adverse events. And they did some mindfulness training during their free hour. And then the control group underwent like a health class, like your standard health class. And they actually saw that they were measuring cortisol levels, so obviously the stress response, and they seemed to have a lower HPA response. So we're trying to shut that down and calm them down so that they can become productive members. If I'm not thinking about what happened last night in my house, then maybe I could learn something while I'm there in the classroom. And finally, tertiary prevention. So we do recognize now that some of these chronic diseases in adulthood are related to these experiences in the childhood. What you want to do as an adult physician would be to screen them for exposure to violence and also screening for maternal depression. We found that this is highly correlated with what's happening in that environment. So if the mom's depressed, then she's not going to be able to respond the best way she can to that child. And so we want to kind of screen for that, and that will be where you implement your primary prevention technically for the child, but it's tertiary prevention for that mom who's already in that depressed state, and how do we help her? So finally, these are just the AAP recommendations that came down the pipeline and how the pediatrician will be kind of learning and going forth. So one thing which we've already done today was to adopt the proposed EBD framework so that we can understand how there is an interplay between lifelong disparities and the early things that happen to kids. Second was that just learning how all these come into play, and they have to be fully integrated into the training of all future physicians. So just learning how these links of toxic stress link to these disruptive problems in the nervous system, cardiovascular, and then how they affect learning and behavior. The third thing was to adapt a more proactive leadership. So like I said, pediatricians are critical to this. People believe you, they like you, and they think, oh, this is great. So they're going to be listening to you both in the setting of your office and then also outside of there. So within communities, educating the general public about toxic stress, what it is, what we need to do in our local Head Start or on a state level. It's just you're going to be shaping the policy, and it's going to be necessary. Fourthly, we need to be vocal advocates for the development and implementation of these new evidence-based interventions. So right now, these things are going to be critical to start implementing, and also money to research it. Like I said, we don't really know exactly how to prevent it, exactly what will mitigate that level of stress. So basically all this is happening within the pediatric medical home, so in the office or at the in the hospital, just learning how we should shape our medical homes. So one, they should strengthen the provision of anticipatory guidance to those moms and parents, actively screen for precipitants of toxic stress, and then kind of help develop and help secure funding for all of this. The issue right now is that there's a lot less mental health facilities now. There's not a lot of funding for that right now. So we know that all this toxic stress and adverse experiences cause all these later chronic diseases, but we don't have the means really to refer them to mitigate that. So where do you send these kids, and how do I educate myself as a physician? How do I learn what type of cognitive behavioral therapy they need, and where do I refer them? It's going to be important. Also, this takes a lot of time, so you have to sit there, learn about them. At the same time, you're supposed to get their vaccines done, recognize all the anticipatory guidance we're already made to do, and you're supposed to do all that in 15 minutes while they're in the room. And that's not possible. So part of the role of the pediatrician is going to be even advocating for us to get paid for that. I think that's a reality that we have to start thinking about. How do you bill for that cycle? So one suggestion was being able to actually bill for, bill for toxic stress and the subsequent visits afterwards to kind of figure out, like you screen for it, then what do you do with it? I have to see them multiple times to kind of put together the whole picture about what's going on. And it's important for us to get paid paid for that. That's our knowledge, our thinking, and kind of interacting with the patient. And so that's going to be very important as you're growing and as you're going out there into the world. So, think about it. And finally, you'll want to identify some local resources just to help that. So no matter where you practice, kind of learn where you can send them, what is available. Despite the scarcity that we have now in the nation, you kind of want to find what's prevalent in your community. What type of stressors are they going through? Do they live in Flint, Michigan right now? So that those things are going to matter. So you kind of want to have toxic stress in the back of your mind, even when they come through the door, and know where to plug them into. And that's it. Any questions?
Thank you, that was really nice. Questions? I think this is really, I think that the dilemma that you raised is really important. A limited amount of time and the lack of reimbursement. And so how would you approach this as an office to try and balance those things at the present time?
I think you have to start it early on. So for instance, I had a child yesterday. So she came in at 2 months old. She's lost a little bit of weight, and it's kind of filling out the family. So then I'm like, well, how many siblings are at home? So she has a 5-year-old, a 4-year-old, 18-month-old, and now this new baby. So maybe the new baby's not getting as much attention at the same time. So you're kind of sitting there to focus on them. Then I'm like, well, who sees this one? There, she's like, oh, well, can we come here? I was like, yeah. So it's kind of, you need to establish that bond with your patients so you can kind of fill them out, let them feel comfortable with you so that they can kind of let that guard down. You can find out what's really going on, because they're going to tell you exactly what you want to hear. They're good at that. We learned that. I tell my doctor that I'm doing everything right and I don't drink any water. So you want to, this is my first class, but you, I think that's going to be what's critical, because you're not going to have a lot of time, but you're going to have to pick up on different cues. So I can tell that that's a handful when she's running around trying to correct this one, and I'm like, hey, can you fill out this PDQ? Like that's a lot going on. The nice thing I think would be to kind of have those things in the office. So let's say I do find that that's going on and there are some stressors, even for the 2-year-old that's running around and they're saying he has ADHD, but is it really ADHD or is that his heightened stress response to something that was kind of going on? I need to be able to filter them in somewhere where they need to go. And if that was available in the office, like one example was telemedicine, like they were able to talk to a mental health professional and say, hey, this is kind of what's going on, this is what I think is going on, and you get some immediate feedback so you know how to treat it or how to prevent it. I think those would be kind of ideal. Like if you could create your medical practice to incorporate them at the same time, I think that would be nice. I love the when you do behavior and development, you go to the development clinic and everybody's there together. So you're discussing the kid as a whole. So yes, you get 20 minutes in the room with them, but then they go see Melody, which looks at their development, their behavior, motor skills, and you kind of discuss that all together. Their diet, they see the dietitian, and all that's incorporated all at one setting. So maybe I spent 15 minutes in the room and I did a physical, but then she spent 15 minutes doing a developmental assessment. And I think that would be ideal to a practice.
Yeah, I think that's a great observation, and I think that's the key, is that you have to have enough of a relationship with the family to be able to pick out what's important for that family, and it may be very different from one family to the next as to what you need to focus on in the limited time that you have. So I think that's a great observation. That's the way to do it. There are data from Mississippi, in the Mississippi Medicaid program, that children whose families establish a relationship with a pediatrician, so the children go to their pediatrician on a regular basis, end up being more successful in high school, going to college, and having reduced risk for these behaviors. So I think that there's already an established role that physicians can play in addressing toxic stress and the negative outcomes. So this is really important for us to pay attention to. So any other questions? Comments? If not, thank you very much. Very nice.